Hello, welcome to video one of our three-part video series answering frequently asked questions regarding pediatric respiratory tract infections. My name is Kristin Schmidt. I am an infectious diseases and antimicrobial stewardship pharmacist with the Sask Health Authority in Regina, and I am joined by Dr. Rupesh Chawla, who is a pediatric infectious diseases and antimicrobial stewardship physician in Saskatoon. The objective of this video series is to answer frequently asked questions regarding assessment and treatment of common pediatric respiratory tract infections encountered in primary care, with the aim of ensuring that antimicrobial therapy is used as appropriately as possible. This first video will cover both pharyngitis and acute otitis media. So to begin with, I will pass things over to Dr. Chawla to give a bit of a background before we jump into the questions.
Thank you so much, Kristin, for the kind introduction. So as Kristin said, we're going to be following about tonsillopharyngitis and acute otitis media today. So just before we start, the one thing that I would like you to recommend for all three of this series that we're going to be going over is that I'd strongly recommend that all of you have the First Line app on your phones. And this is available for free on both the Apple Play Store as well as the Google Store. The main thing that we want to make sure that you have is that at the top of your First Line, it should say the Mom and Kids or the Jim Pattison Children's Hospital at the very top. And that's the pediatric guidelines, as there are very different ones on there. You're going to find the majority of the talks that we're going to have, including acute otitis media, tonsillopharyngitis, and sinusitis, all in the head and neck section. And you're going to find pneumonia on its own section, the community-acquired pneumonia guidelines. So we're going to start with tonsillopharyngitis today. And I want to start with saying that basically almost all cases of tonsillopharyngitis are related to viral causes. But the important thing is to find out when is streptococcal bacteria responsible. And there are some other bacterial agents that can be responsible. But I mean, the big point is when do we treat and when do we not treat tonsillopharyngitis? And we'll start with some of the questions with Kristin.
All right. So first question, what exactly is the Centaur score and how does this help diagnostically?
Thanks so much, Kristin. So the big point is, as I said, the majority of cases of tonsillopharyngitis are related to viral causes. And the other important point is that group A strep is a very common colonizer in the oropharynx. So we want to stop people from doing throat swabs and treating if there's a lot of viral symptoms and a throat swab comes back positive for group A strep. That's not a group A strep infection. So the reason why we have created this score, this Centaur clinical decision tool, is to not decide who you're going to treat, but who you're going to swab. So if they have significant number of viral upper respiratory tract symptoms, they have a viral upper respiratory tract infection, they should not be swabbed, they should not receive antibiotic therapy. However, for children aged 3 to 14 years, this tool can be quite useful to see who you would swab. So for each of these age groups, you get 1 point for a presence of an exudate or swollen tonsils. Second, tender or swollen anterior cervical lymph nodes. Third, fever. And fourth, the absence of cough. So if you have a score that's greater than or equal to 3, that is when you do a throat swab. If it's under that, you do not need to do a throat swab. It's an upper respiratory tract infection that's viral and do not treat. The important thing to note here is that even in those situations where there's 3 or 4 positive on the Centaur score, you can see that even at the best, it's at maximum 56% of those are group A strep infections. So recognizing again that no matter how bad the throat can look and how severe the symptoms can be, sometimes these are still viral illnesses that are causing the pharyngitis.
Okay, I know it can be a bit tricky when parents come into the clinic and they're expecting throat swabs and expecting antibiotics, so probably important to explain, the use of this tool and what the risk is for viral versus bacterial infection. So for question number 2, for a confirmed group A strep pharyngitis, what would be the antimicrobial treatment of choice and what would be the recommended duration of therapy?
So we're going to get into a little bit in terms of the length of therapy based on why we treat tonsillopharyngitis. But in terms of the antibiotics for tonsillopharyngitis, the first and foremost important point for treatment is that we should use a very narrow spectrum antibiotic. So the best choice is pen V if possible. The problem with Pen V is the lack of an oral suspension. But if they can take a pill, Pen V is the treatment of choice. So recognizing in terms of, as per this chart, if they're less than or equal to 27 kilograms, to use of 300 milligrams of the pill, either twice or 3 times a day. And the treatment there is 10 days, and we'll explain that why. And if they're over 27 kilograms, 600 milligrams of the penicillin pill, 2 or 3 times a day. Now, in kids where they are not able to sometimes take the pill, the next choice would be amoxicillin at the dose that's listed there, 50 milligrams per kilogram per day. Now, realistically, it states there that it's given once a day. Really, how antibiotics work, we would very much prefer that we don't use the once daily dosing, and we strongly recommend using the twice daily dosing, so 25 milligrams per kilogram twice a day for the 10-day course. You can use the benzathine intramuscular, but realistically, that is a very difficult medication to find and not a very common choice for most parents and families to want to go to. Lastly, in terms of medications, it's important to recognize that a lot of people state that they have an allergy to penicillin and worry about rash or worse symptoms, and they've had an issue with this before. We need to recognize that realistically that most cases of self-reported penicillin allergy are probably not true penicillin allergy and are likely related to a rash related to a virus. And when you give an antibiotic to a virus, it often rashes. So there is a tool actually in First Line that you can go to really assess whether true penicillin allergy occurs. Okay. If you do have a true documented anaphylactic type reaction, of course, you do not want to use a beta-lactam antibiotics. And as listed on the chart there, you can use azithromycin, clarithromycin, or clindamycin at the doses listed below. If you do not have a non-type 1 type allergy, you can consider cephalexin, but again, this is where it's really important to go through that tool and make your choices appropriately.
Absolutely. Thank you for highlighting that tool. Often what gets reported is kind of this delayed benign rash, right? That happens quite often, which is not a contraindication to using beta-lactams in the future, but the tool will help to assess that. All right, moving on to the next question. As you kind of mentioned at certain points, often these cases of pharyngitis are viral, and even if they are bacterial, they can be self-limiting. So why is it that we need to treat group A strep pharyngitis in kids?
Thank you so much, Kristin. I think the big point is, I think a lot of us feel that we are treating tonsillar pharyngitis to make people feel better. And realistically, that's probably not the main reason that we give therapy for tonsillar pharyngitis for group A strep. There's a variety of reasons why we do use it. So probably the big one that we want to think about and why the 10 days occurs is what we call preventing non-suppurative complications. Now, the non-suppurative complication that it does prevent is rheumatic fever. And the data for rheumatic fever is that you do need 10 days of therapy to prevent rheumatic fever. And that's why the recommendations really haven't changed from the 10 days of treatment. There have been studies that have shown that you can actually eradicate the group A strep faster, but no studies have yet proved that that will reduce your incidence of rheumatic fever. So you need to treat within 9 days with a 10-day course of antibiotics with this penicillin or amoxil to really reduce that risk. So that's the main reason that we give the treatment. But it can also prevent suppurative complications, so which are pus-forming complications, such as retropharyngeal abscesses, cervical adenitis, so worsening in terms of spread of the group A strep in the oropharynx and into other sort of deep tissues. It does alleviate clinical symptoms, but realistically not longer than about a day. So I said, though that parents and people feel that that's the real reason that they want to use it, we're not using it for that because it really doesn't make a huge difference in terms of how you feel. The other big point that we use group A strep therapy for is really for people to be able to go back, for these kids to go back to school, to daycare, and also we want to prevent spread to close contacts.
How long after starting treatment is someone considered non-infectious and it would be okay to go back to school or daycare?
After 24 hours of therapy, Kristin, it's fine for them to go back to daycare. And so full 24 hours of the pen or amoxil therapy.
Okay, great. Thank you so much. Let's move on to acute otitis media.
Perfect. So acute otitis media is a very, very common infection. So in terms of incidence, by the time a child goes to school, about 75% of kids will have had at least one episode of otitis media. Now, acute otitis media is a symptomatic bacterial disease that occurs after initial viral illness. So most cases of otitis media, however, in patients over 6 months of age do self-resolve with the bacteria that causes them. So some of them do not require antibiotics. So that's what we're going to really focus in on this talk.
Okay. All right. So jumping into our questions. First one, how does one properly assess a patient with suspected acute otitis media and confirm that diagnosis?
Great question, Kristin. I think probably one of the hardest points is a good diagnosis of an acute otitis media. So when you're talking about acute otitis media, you need three things to be present. You need a symptomatic child. You do not have a red ear and without symptoms is not acute otitis media. Second, you need the presence of a middle ear effusion. So that's where you get that opaque area behind the tympanic membrane, and often a retraction or bulging of that membrane. And third is inflammation, that redness over that area. So if all three are present, you have a good diagnosis of otitis media, and we will follow through on this flow chart, which is through the CPS, and that's actually a great way to sort of approach things as well. All of this flow chart is actually highlighted through the First Line app. If you follow on the First Line app, it will sort of take you through this whole process by just a click box and in regards to the symptoms and what you do. So we'll start with the first on the left. If you have a otitis media where there's a perforated tympanic membrane with purulent drainage, you do want to treat with antibiotics, and you want to treat for a total of 10 days. Now, we're going to be talking about the antibiotics with the next question, but we'll sort of go through sort of the courses for each of those. The second case is what we talked about before. So if you have an appropriate diagnosis of a middle ear effusion, a symptomatic child, and a bulging tympanic membrane, then you are going to generally then split those into a mildly ill child or a moderately or severely ill child. If the child is mildly ill, is alert, responsive, has fevers that do respond to antipyretics, the fevers are less than 39 degrees, and symptoms are less than 48 hours, the general rule is to watch and wait. Give them, 24 to 48 hours. If things are getting better on their own, they do not require antimicrobial therapy. That's a self-resolved otitis media. If, however, those symptoms are continuing, we do recommend therapy. So there on the bottom there, it's a 10-day course if you're 6 months to 2 years, and a 5-day course if you're greater than or equal to 2 years of age. Now, generally what I recommend, because most family practices are quite busy, is just like with the pharyngitis, to provide them with a prescription to hold on to so you can save them from coming back, and then only fill it if those symptoms are not getting better. Now, if you look at the moderate or severely ill, again, those temperatures are greater than 39, fevers are not coming down, there's irritability, difficulty sleeping, or symptoms that are over 48 hours, the general recommendation is to not wait, just go right to the treatment. So the 10 days if you're 6 months to 2 years, and 5 days if it's greater than or equal to 2 years. Last situation is, as we stated there, if you do not have a middle ear effusion, or if there's a middle ear effusion that there's no erythema in it. So you want to very strongly consider a viral etiology there, and basically no antibiotic therapy. If in 24 to 48 hours it's not improving, that is the situation where you do want to bring them back in to get them reassessed. In those situations, probably best not to give them a prescription for antibiotics, but get them to get reassessed, because really we're probably not treating a bacterial infection at all there.
Okay, so you've kind of touched on this already, but now we can go into more detail. So when is prescribing antimicrobial therapy appropriate, and when can we practice watchful waiting with acute otitis media cases?
I think we basically answered that question, Kristin, with this last one. Mm-hmm. But I think now what we want to talk about is which sort of antibiotics we'd be using, and how do we make that decision for which antibiotic we use. The big point here is that I think a lot of confusion occurs with high and low dose of antibiotic therapy for the amoxicillin and the clavulin. So really, what we want to look at is what makes a child more likely to be antibacterial resistant. And the bug that we're talking about here is strep pneumonia. When we're treating acute otitis media, there are a variety of bacteria that can be involved: strep pneumonia, H. influenza, non-typable, Moraxella catarrhalis, and sometimes very occasionally group A strep. But really the organism that we focus therapy on is the strep pneumonia when we're giving therapy. And that's the bacteria that can have resistance. So the two biggest risk factors for resistance in the strep pneumonia bacteria are what's highlighted in red. One is attendance in out-of-home daycare, and second is antibiotic use in the preceding 3 months. Another risk factor that is also considered is young age, if they're less than 5 years, and especially if they're less than 2 years. And really, if you have the presence of those risk factors, 1 or 2, especially the red labeled ones, you want to use a higher dose of antibiotic therapy. And we're going to highlight that in the next slide. The important thing to recognize here is, just like with pharyngitis, is that really the treatment of choice is an amoxicillin. Okay? It's not to use broad spectrum antibiotics. You want to use the most narrow spectrum antibiotic that really covers the strep pneumonia bacteria well. The reason for that is often if you have an infection with the H. flu or the Moraxella catarrhalis, those are bacteria that often self-resolve without therapy. So when you use the treatment, and if you had, we said in the last slide, no resistance risk factors, you should use a standard dose of amoxicillin at 40 to 50 milligrams per kilogram per day. And that should be divided at a TID dosing when you're using the standard dose. If, however, you have a high-risk patient for resistance, then you want to go up to the high dose amoxicillin dosing of 80 to 100 milligrams per kilogram per day. And that can be divided BID. Just with the higher dose, you're going to maintain that amoxicillin level at high enough levels that you're going to see ongoing killing of the bacteria, but only using the BID dosing when you're using the high dose, not for the standard dose. Just like we talked about for patients with tonsillopharyngitis, for those patients who have true documented penicillin allergies, again, please use the First Line app to see if they do fit a true penicillin allergy. You can use with type 1 allergy a macrolide, but recognize that macrolides are not as good for treating strep pneumonia as the amoxicillin is. If you have a non-type 1 allergy, you can use a second-generation cephalosporin like cefuroxime or cefprozil for therapy. Lastly, clavulin should not be used as first-line therapy for acute otitis media. When we use clavulin, we are saying that the strep pneumonia may not be the only pathogen that's causing the problem, and maybe the H. flu and Moraxella, which produce a beta-lactamase that would basically make the amoxicillin not functional, may be causing the infection. So realistically, clavulin should never be used as first-line therapy, but should be used when you fail amoxicillin or other first-line therapy. And then you go to clavulin, whether you use the low dose, which is again the 40 to 50 milligrams divided TID, or the high dose, which is 80 to 100 milligrams divided BID. And please look at our monograph in regards to how to prescribe high dose amoxicillin clavulanic when you do it. Thank you.
Wonderful. Thank you for those details. Important to ensure that people understand that it's not the amoxiclav that overcomes the possible strep pneumo resistance, right? It's that higher dose of amoxicillin. So clavulin isn't needed if there could be resistant strep pneumo. So to close things off, thank you so much, Dr. Chawla, and also thanks to our viewers out there. Please check out the other videos in this series as well as the other resources that are included in the bundle. And if you'd like to further this discussion, we invite you to attend a live webinar and Q&A session with both myself and Dr. Chawla during World Antimicrobial Resistance Awareness Week on November 21st at 12 p.m. We hope to see you there.
Thank you so much, Kristin.